Good evening, everyone. My name is Bojana Beric-Stojšić. I'm the Associate Professor of Public Health and Founding Director of FDU and PH online program and the Chair of the Planning Committee for the Symposium. I would like to welcome you all to our inaugural Interprofessional Collaborative Practice Symposium. And I would like to ask Dean Rifkin to address the audience, to open the symposium.
Sure, Bojana, thank you. Can everybody hear me? Yes, great. Good evening, everyone. I'm delighted to welcome you all to the Interprofessional Collaborative Practice Symposium. As Bojana indicated, our first one. We are very excited. It is hosted by the School of Pharmacy and Health Sciences. My name is Anastasia Rifkin, and I'm the Dean of the School of Pharmacy and Health Sciences. I'm a pharmacist by training, and in my professional career, I have worked with and gained enormous respect for all the professions we have joining us as speakers and panelists today, including public health professionals, nursing, occupational therapy, pharmacy, physician assistants, and social work. The healthcare landscape is rapidly changing, and the challenges we face are becoming increasingly complex. Teams that train together during their formative years develop experts that work well with each other, helping patients and their families. Such teams ensure that our patients receive the highest quality of care and that we are prepared to meet the evolving needs of our communities. Team members share their knowledge and skills to achieve common goals, ultimately leading to improved patient outcomes. At least that's the hope for the team-based care. At our school, we recognize the importance of interprofessional collaboration and have made it a cornerstone of our educational programs. By bringing together students from different healthcare disciplines and providing them with opportunities to learn and work together, we are preparing our future healthcare professionals to work collaboratively and effectively on interprofessional teams, putting patient in the center of care. Today's symposium provides us with a unique opportunity to engage in meaningful discussions and learn from each other's experiences. I encourage you all to take full advantage of this opportunity and participate actively in the various sessions and activities planned for this evening. Thank you, and I look forward to a productive and inspiring sessions that are planned. I want to provide special thank you to IPE, or Interprofessional Education Council, that was in charge of some of the program, and that includes Dr. Dong-Mi Kim, Dr. Antonia Carbone, Dr. Lydia Westrich, Dr. Justin Buccio, Dr. Jane Steinberg, Dr. Bojana Beric-Stojšić, Dr. Michael Rota, Dr. Andrea Cole, and Dr. Christine Mueller. And these names that I just read represent all professions that we have in the School of Pharmacy and Health Sciences. And I specifically want to highlight the planning committee for the symposium, which was a small but very productive committee. Michelle Beauvais, Dong-Mi Kim, and Seema Shah, who is MPH candidate, who is also joining us this evening. And of course, Dr. Beric-Stojšić, who is the chair of the committee delivering the symposium today. Thank you for great work, and I look forward to the symposium. I now will pass the floor back to Dr. Beric-Stojšić to get us started.
Thank you, Dean Rifkin. Thank you, Anastasia.
Of course.
For inspiring and supportive words, and for the support throughout this process. So I just would like to, as we mentioned, I wanted to again acknowledge my small team or planning committee, Professor Michelle Beauvais, Public Health, Professor Dong-Mi Kim, Pharmacy, and our intern, Seema Shah, our student who will be graduating in May. With masterful support of Justin Skombik and his team, we are presenting our inaugural practice symposium virtually today. We welcome you all to the symposium. I would like to spend just a few minutes to address the importance and timeliness of this practice symposium, focused on interprofessional and interdisciplinary collaboration in healthcare. The first steps in that direction, the future healthcare professionals, our students take in our classrooms and our courses. We at the School of Pharmacy and Health Sciences wanted to make sure that every student enrolled in our 5 programs, pharmacy, social work, physician assistant, occupational therapy, and public health, is exposed to and immersed in IPE learning processes and experiences. The goal 1 in our strategic plan, we will prepare future health professionals who are committed to comprehensive, interprofessional, patient-centered, and population-based care, with its objectives and activities, is purposefully designed to provide opportunity for those initial through the advanced steps in both interprofessional research and practice. Therefore, the keynote and panel speakers for this program are carefully selected with this purpose in mind. The keynote speaker, Elizabeth Weist, is the Director of Education for the Association of Schools and Programs of Public Health, where she leads its learning, accreditation, and interprofessional initiatives. Ms. Weist also serves as the association's representative to the Interprofessional Education Collaborative IPEC Advisory Group, contributing to both 2011 IPEC Competency Development Process and 2016 Competency Update, and she is co-leading the current 2021-2023 Competency Update Initiative. Ms. Weist has worked and studied on 4 continents, spanning the governmental, private, and nonprofit sectors, with 25 years of dedicated service to academic public health. In her daily work, she collaborates with constituent leaders and partners to deliver events and resources that position member schools and programs in successful evidence-based teaching and learning for collaborative practice. Ms. Weist earned her Master of Public Health degree in International Health Promotion from George Washington University, Milken Institute School of Public Health, Master of Arts from the University of Virginia, and a Bachelor of Arts from James Madison University. With great pleasure, I open the podium to you, Ms. Weist.
Thank you so much, Bojana, and also thank you to Dean Rifkin. And it's so exciting to join all of you this evening in your inaugural symposium. I will share my screen. Everyone see it okay?
Yes.
Yes, all right. I'm Liz Weist, and our conversation today is on the theme of interprofessional education for a changing health ecosystem and for changing the health ecosystem. Just need to reduce the photos there. I'd like to start off with this great quote relevant to today's health ecosystem. The healthcare system will not be able to keep pace with today's explosive changes unless it moves to a team-based care model. But the delivery system cannot make that shift effectively until the education system begins to train new health professionals in collaborative practice. Our time together this evening will cover 6 parts: the key IPCP players, our health ecosystem, the challenge, incomes IPE, changing our health ecosystem, exemplars, and are you ready for IPECP? First, the key IPCP players. Starting off with my shop, the Association of Schools and Programs of Public Health, or ASPPH. We are the voice of academic public health representing schools and programs accredited by the Council on Education for Public Health, or CEPH. ASPPH is growing, and just last week we added a new program. So we have 142 members in our family. 65 are freestanding schools of public health, 73 are programs, such as your MPH program. And these programs are housed in med schools, schools of education, and there's even one in a school of pharmacy like yours, and that's Florida A&M. 6 are global, and 4 are associate members, which means they're on the path to accreditation. ASPPH is a founding member of the Interprofessional Education Collaborative, or IPEC, launched by 6 national education associations in 2009 to inspire, lead, and support the field in interprofessional education for collaborative practice. I sit on the advisory committee for IPEC with the 6 foundation associations you see here on the screen, plus social work, which was added to the board more recently. IPEC hosts biannual faculty development institutes, leadership programs, webinars, and more. Here's a photo from one of our institutes. I know that some of you have come before. That's where I met Dr. Beric Soychik. And the purpose is to have the attendees graduate as effective faculty champions. So you go back to your schools and programs and you're able to lead this. I look forward to seeing the team from Fairleigh Dickinson who's coming to next month's Virtual Institute. Specifically, IPEC fosters a common vision for team-based health delivery. We promote efforts to reform the health system, and we contribute to developing leaders and resources for interprofessional learning. What began as a partnership of just the 6 associations you saw has grown to represent 22 members, with the most recent being the Academy of Integrative Health and Medicine, who just joined us in January. With such a diverse and comprehensive set of associations working together, optometry, PT, podiatry, vet med, just to name a few, our vision of collaborative and patient-centered care for improving the health of our communities becomes more and more a reality. There's some other players in the field that I need to call out, and ASPPH and IPEC, we play very nicely in the sandbox with them. The National Center for Interprofessional Practice and Education, funded to provide the leadership evidence and resources needed to guide the nation in this area. The National Center introduced an interesting conceptual bridge between IP education and collaborative practice that they call the nexus, recognizing that learning in education and practice and education is inextricably linked, it's nonlinear, and it spans the continuum from the classroom to community and practice. This shift in thinking moves the emphasis from the classroom, to practice and community settings to align IP education with health systems redesign. Now, we sometimes get the question, do the health professions accrediting bodies talk to each other? And thankfully, the answer is a resounding yes. The Health Professions Accreditors Collaborative, or HPAC, convenes the health professions accrediting bodies to cooperate, ensuring that their standards, policies, and procedures support and prepare grads for contemporary practice as part of interprofessional teams. Most of HPAC's members represent accrediting bodies that are aligned with IPEC, so roughly about 22 members. Both of these groups have important resources that are free for perusing and downloading. Just to make sure we're operating from the same foundation, here's the most popular definition of IPE, issued in 2010, when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. It's from the World Health Organization. ASPPH, IPEC, and HPAC have adopted this definition, and the National Center has adopted a slightly revised definition. Let's move on to our health ecosystem, the challenge. The Institute of Medicine updated their graphic of the health system with the idea that health is much more than a clinical care delivery system. You could see governmental public health, city, county, state, federal, and tribal at the center, holding the system together. I honestly believe that not too many people understood its role until the COVID-19 pandemic. The constellation surrounding governmental public health, starting in the upper right, of course, involves clinical care, but also moving clockwise, employers and business, the media, education, and not just higher ed, but K through 12, governmental agencies other than public health, such as transportation, housing, and commerce, for example, and of course, the community. The earliest IP efforts began over a century ago, and team-based care theory has been around for 50 years. But the big impetus came in 2000 with the Institute of Medicine's report on the deficiencies in IP coordination, communication, and teamwork within the healthcare delivery system in the US. They published "To Err is Human, Building a Safer Health System." That report was the first of a trilogy that included Crossing the Quality Chasm, a new health system for the 21st century in 2001, and then in 2003, Health Professions Education, The Bridge to Quality, all foundational documents. These reports introduce health professionals to work together in teams more effectively, and that the lack of teamwork, collaboration, and communication skills was implicated in a wide range of adverse patient and health outcomes in the world's most costly, by far, health system. As US healthcare industry leaders responded and led transformation, recognition grew that the graduates of health profession schools may be technically competent, but are not ready to practice in today's evolving health system. As a result, many healthcare leaders and educators began calling for new models of education with a more ardent desire for IPE linked to collaborative practice for team-based care. Since those groundbreaking reports, the US healthcare delivery system has been transforming in profound ways. But a generation later, many of our students are still learning in silos. This narrow vision of the kind of clinical and public health practice we need stymies our ability to work together most successfully to protect the public and improve population health. Incidents play out in the health professions to the detriment both of healthcare teams' effectiveness and the people we serve, who desperately need better coordinated care, communication, programs, and services. To this day, most interprofessional ed and collaborative practice work has been small, experimental, and fleeting as we struggle for resources and support. When we don't learn together, we inhibit the ability to communicate. And when we do talk, we often don't understand what our colleagues mean. It's as if we speak different languages. I'm going to cover a few of the challenges to collaborative practice in today's health ecosystem. The growing complexity, data and IT, lots of it, pun intended. Increased expectations on health providers, changing mandates for health professional competence, job burnout and turnover, demographics, aging and chronic disease. First of all, the growing complexity. In 2011, US physicians had 2,700 clinical practice guidelines to follow. And while the counting seems to have changed, we do know that 88 new guidelines were added just in 2022. In another report by NIH of clinical studies, we have almost 500,000 currently in progress. More on the growing complexity of practice. The 2022 study revisiting the time needed to provide adult primary care, reported in the Journal of General Internal Medicine, examined the time a physician would need to provide guideline-recommended preventive chronic disease and acute care. This job requires nearly 27 hours in a day. However, in team-based care, thanks to the mutual support and collaboration among the team members, this time was reduced to 9 hours a day. Of the 17 hours, the study reported that could be shifted to other members of the health team, the majority of time reduction was due to 11 hours of counseling tasks transferred to dietetics or counselors. Second, data and IT, lots of it. Physicians, just to take one, are increasingly required to use technology that interferes with rather than facilitates their care. The clinical documentation burden alone, which could be exacerbated by the widespread use of electronic health record systems, is having a negative impact on healthcare. The National Library of Medicine reports that this burden is linked to overall clinician burnout and decreased job satisfaction, medical errors, and hospital-acquired conditions. The pandemic increased recognition of the role of clinical documentation on workload. Increased expectations on health providers include having to control costs and use resources more efficiently, assure patient safety and improve access, such as demonstrated by patient-centered health homes and by accountable care orgs, more demand from providers, clients, and communities to enhance the quality of care, health, and well-being, including the impetus for improved health outcomes, calls for more compassionate care, growing interest in personalized health and genomics, stronger awareness of prevention and the role of upstream actions and policies on health. An example of increasing expectations, and don't get me wrong, everything I'm covering is important to address. The triple aim was recommended in 2007 as a framework for healthcare to, starting at the bottom, improve the patient experience with better care, lower costs, and result in improved health for individuals and populations. A fourth piece was added, making it the quadruple aim for health in 2017, with important attention paid to improving the work-life balance of healthcare providers. Followed by the quintuple aim in 2019, adding important attention to equity and inclusion, both for health outcomes and within the health team. Fourth, changing mandates for competence. Getting up to speed with these changing mandates includes healthcare systems and employers who want interprofessionally trained health professionals who can collaborate and function in a team and who can coordinate health systems and programs. Federal systems have been realigning, such as the military, leading through team steps, and the VA, which has formed patient-aligned care teams, or PACs, that involve each veteran working together with healthcare professionals to plan for whole person care and lifelong health and wellness. Most health professions accreditation competency standards are including criteria for interprofessional learning. And finally, the IPEC core competencies are under revision for release this year, and more about that a little later. Public health has long considered the social determinants or root causes of health in its wheelhouse, but other health professions are now looking more upstream at the factors that assist or hinder health and wellness. Here you could see some examples of the sectors that have a bearing on health. Remember our graphic earlier of the health system? What this looks like in practice from the perspective of a public health agency is shown here, an intricate, complicated, and interconnected web. Fifth, job burnout and resulting turnover in public health and other important fields for health and wellness. These data from the de Beaumont Foundation and the Association of State and Territorial Health Officers show that nearly half of state and local health department employees left their organizations from 2017 to 2021. Wonder why? Looking at our clinical partners, 1 in 5 U.S. healthcare workers have left the profession since 2020, and close to half of healthcare workers plan to leave their current job by 2025. In addition to the suffering that public health workers are experiencing, the organizational loss and experience, institutional and content knowledge, and the connections with communities based on personal and professional relationships put all of us at significant risk for infectious diseases and other health crises. As reported in yesterday's Wall Street Journal in the book review of If I Betray These Words, Moral Injury in Medicine and Why It's So Hard for Clinicians to Put Patients First, today's physicians are seeing more patients in less time with fewer support staff, and they're weighed down by increased bureaucracy, lack of respect from staff, lack of respect from patients, and burgeoning governmental regulations. As a result, our healers are left feeling exhausted, cynical, alienated, and ineffective. The authors choose to call this untenable situation today not burnout, which places the blame on the clinician, but moral injury, which indicts our system as the root cause of the problem. Moving on to our sixth challenge to collaborative practice in today's health ecosystem, we have demographics, particularly the aging of the US population, steady increase in chronic disease, and continued growth of obesity, which are responsible for rising costs and great pressures on our system. The chart here depicts the explosion of the elderly in the US. Looking at our annual healthcare expenditures, 90% of our nation's $4.1 trillion are for people with chronic and mental health conditions. Let's look at the number of chronic conditions per Medicare beneficiary, showing that the management of chronic care drives the system. The first column shows the number of chronic conditions. The middle column shows the percentage of beneficiaries with each number of conditions. And the math indicates that approximately 63% of Medicare beneficiaries have more than one chronic condition. The third column shows expenditures, with over 95% of Medicare expenditures going to Medicare beneficiaries with more than one chronic condition. Well, in comes IPE. What could we do about it? Preparing students interprofessionally for successful collaborative practice starts with an act of the will. Fairleigh Dickinson School of Pharmacy and Health Sciences strategic plan through 2026 has as its first goal to prepare future health professionals who are committed to comprehensive, interprofessional, patient-centered, and population-based care. That's a school I would want to attend, and I laud your prioritization of exactly what is needed for meeting the challenges just described. Looking at some of the literature on IPE, the Lancet Commission report in 2010, Health Professionals for a New Century, was a landmark document for IPE. The commission brought together 20 professional and academic leaders who recommended sweeping change in the training of health professionals across the entire health ed system. The graphic models of inter- and trans-professional education was created by the commission. It depicts along the top row, in red, the dominant model of health professions education, in which you could see, look at the green, how nursing, medicine, public health, and others learn in their own disciplines uniprofessionally, and then are expected, magically, we could suppose, to work together in the field. This is a very challenging proposition for people taught in isolation from each other. Most institutions across the globe, the commission found, followed this model. Moving to the blue row, increasingly, schools are beginning to weave IP competencies into student learning and facilitating teamwork in education and training. The model of the future, the commission predicts, that will have the most impact on population health is the bottom row, transprofessional. In it, community health workers and others are brought to the table to both teach and learn about, from, and with medical, nursing, public health, and other students while they are still in school, so that these sets of individuals, upon graduation, can work more successfully in the field. The 22 update to the original Lancet Commission report reviewed developments in the 12 intervening years. Focusing on the IPE piece, the authors observed most IP studies focus on doctors and nurses in clinical settings. Hot topics such as palliative care, pain management, and patient safety are ones that translate well into IPE experiences. Real-world settings for experiential learning offer IP students a view into disparities and help build their shared sense of social responsibility. Socializing students to develop a professional dual identity integrates their uniprofessional learning with IPE. The authors also point to a continuing need for literature outlining successful IPE implementation, more financial and organizational support, and faculty development, especially since many of our faculty were not trained in IPE. We know intuitively that stronger teams lead to improved care, increased patient satisfaction, and clinician well-being, but how can we prove it? IPEC recently partnered with the Association of Academic Health Sciences Libraries to conduct a scoping review to look at the evidence linking IPE interventions and the quality of patient care. From these key specific measures, the scoping review indicates that most of the studies in each of these areas had a positive impact, linking IPE to a direct improvement in quality of patient care, plus a few other health outcomes. The question that the researchers asked was, has the inclusion of IPE in healthcare curricula had a direct impact on the quality of patient care? We have some pre-publication findings to share with you that are really exciting. First of all, the team searched a number of databases for papers published between 2015 and 2021. The initial inclusion criteria for eligible papers was studies written in English, publication dates from 2015 to 2021, use of qualitative, quantitative, or mixed methods, inclusion of healthcare professionals, students, or practitioners who had IPE training, inclusion of all types of interventions that target any type of health or social care. Intervention must have been conducted by 2 or more collaborators. IPE exposure must have been within formal coursework or other professional education, and that there were measures of direct patient outcomes. Here is what the researchers found in studying 5 quality measures related to patient care. Length of stay decreased by 67%. Medical errors decreased by 77%. Both patient satisfaction and patient caregiver education were strong, with 95% of the studies indicating an increase in both areas, and mortality decreased by 50%. There are several conclusions in the paper, but I'll highlight 3. IPE positively impacts the quality of patient care. There is an urgent need for more IPE interventions to enhance patient outcomes. We have a continuing need for active collaborative learning with other disciplines. Once the article is published, I'll look forward to sharing it with you. Let's move on to IPEC's biggest contribution in its report, Core Competencies for Interprofessional Collaborative Practice. Released in 2011, the report, written by a consensus panel, proposed 4 domains of core competencies, and this report was updated in 2016 to include population health more intentionally. The 4 core competencies are values and ethics, roles and responsibilities, interprofessional communication, and teams and teamwork, and I know you all use these. The competencies are shown here in a learning continuum, and they are centered within patients, families, and populations across the full spectrum of care. IPEC's core competencies have been widely disseminated throughout the world and are embedded in both curricula and accreditation standards across the professions. In fact, in a report published by IPR Global in October of last year, it was noted that across the globe, the IPEC core competencies are the most widely used competency framework of any model. Our friends in Canada, their framework came in a very close second. We are right now in a multi-year process of updating the IPEC core competencies. Why? After 5 years, the board felt it was time to revisit the 2016 version. IPEC had grown significantly since that update, and it was time to review the competencies through the perspectives of IPEC's full membership. To take that idea of inclusivity and collaboration even further, IPEC wants to engage and empower the IPE and collaborative practice communities, such as you all, around this effort. And in light of today's ever-changing health landscape, we want to make sure the framework reflects current research, policy, and practice, especially after everything we learned in COVID. What are some proposed changes? Using a community engaged process detailed on the IPEC website, you may be wondering what are some examples of the proposed changes in the framework. Here's a preview. We've heard in our surveys and town halls to include the following concepts: DEI, leadership, the concept of One Health, importance of well-being and resilience, and team science. All important concepts that you will see have been infused into the updated draft. We encourage you to share your thoughts about the upcoming final draft competency set online. You can send us comments. Actually, it may be actually online today. You could send comments on our website under the comment form tab, and there's the URL at the top of the screen. You could also join us online for an open town hall discussion. The first one we're having is Tuesday, the 25th of April from 2 to 3:30 p.m. Eastern. Registration for this event is open, free of charge. Registered participants will be asked to review the 2023 slate prior to that meeting so that you're ready to engage with the new model and to discuss the changes. And thank you, Dr. Berich-Stoichis, for putting into the chat the link to join up. Now, what can we do for changing our health ecosystem? I love this quote by Dr. Francis Omaswa: universities must be felt by their communities. IPE for collaborative practice is one of the best gifts that we as university leaders, faculty, staff, and students can share humbly with our neighbors and with our surrounding communities. Changing our health ecosystem begins with a call to action for IPE in our colleges and universities that leads to successful collaborative practice and that provides quality health along with patient and community safety. Complex care that is person and family-centered and community and population-oriented demands it. Achieving optimal health outcomes requires it, and patients and communities increasingly expect it. In chronic cases, interprofessional collaboration, such as with public health, helps to illuminate the larger picture, offering interventions for disease prevention through health education and simple check-ins to support compliance with meds and encourage other healthy behaviors, for example. Community guide evidence from 31 studies from the US and other high-income countries found that engaging community health workers, or CHWs, in collaborating with patients, physicians, nurses, and other providers led to large improvements in blood pressure and cholesterol outcomes. Embedded community health workers, such as in this photo, help people manage risk factors and prevent cardiovascular disease, as well as reduce health disparities. A primary care and public health collaboration of Medicaid providers, local hospitals, and the health department in Durham, North Carolina, working to reduce asthma, trained community health educators to go into schools and to train children how to use inhalers and spacers. They reached out to parents, churches, and neighborhoods to discuss treatment, and they facilitated dialogue among the local primary care providers and asthma specialists to find a common treatment approach. The results were dramatic in that ER visits dropped in just under 2 weeks. The collaboration also led to a countywide standard protocol that was eventually adopted throughout the state. The Community Preventive Services Task Force recommends collaborative care for managing depressive disorders based on strong evidence of effectiveness in improving depression symptoms, adherence to treatment, response to treatment, and remission and recovery from depression. The recommended intervention uses case managers to link primary care providers, patients, and mental health specialists. Collaborative care models typically employ case managers to support primary care providers with functions such as patient education, patient follow-up, to track depression outcomes and adherence to treatment, and adjustment of treatment plans for patients who do not improve. Primary care providers are usually responsible for routine screening and diagnosing of depressive disorders, prescribing antidepressants, and referring patients to mental health specialists as needed. These mental health specialists provide clinical advice and decision support to primary care providers and case managers. Looking globally, UNESCO is one global body calling us to knowledge-driven actions that transform higher ed for sustaining our planet. We are encouraged to extend ourselves beyond disciplinary boundaries, to coordinate our scientific practices, data concepts, and theories, to open up ourselves to new ways of knowing, such as the imperative of becoming open institutions and fostering different ways of thinking and acting. for higher education to have a stronger presence in society through proactive engagement and new and stronger partnerships with other societal actors. Looking at the typology of interprofessional education, and this is from the 22 Lancet paper I mentioned earlier, we're needing to move beyond health professional ed that merely engages clinical learners with public health and related other health professions learners. True transprofessional education stretches us to engage non-professional learners, such as community health workers, and beyond, to non-professional learners who will work in and or with health systems. Some examples include colleagues in IT, data science, arts and architecture, supply chain management, communications, etc. We saw wonderful interactions among these groups and health professions in the pandemic, and we don't want to lose that. We want to grow in these learning and practice partnerships. I just want to point out that there is a new IPE, institutional assessment tool, created by a pharmacy-led team of IPE researchers. They developed and validated this tool that identifies institutional characteristics tied to successful implementation of high-quality programmatic IPE. You could check out the article in the Journal of Interprofessional Education and Practice, just published in October of 2022. The Robert Wood Johnson Foundation conducted a study that led to a set of guiding principles that describe the elements necessary to start or improve an environment and culture of interprofessional collaboration, and we could apply this to the education side as well. The guiding principles issued by the report are that it takes time. This work does not happen overnight. It takes patience and perseverance to build, and it needs to be supported by leadership. Relationships matter. People are the building blocks of teams. Developing relationships between and among team members makes the difference. Pockets of interprofessional practice already exist. And creating this environment is not a linear process. If you look, you'll find that interprofessional efforts are already happening in small ways inside your organization. These pockets of promise can be highlighted, resourced, and spread. Name it. The term IP collaboration might be viewed as a transitional concept until it becomes embedded in the culture. In other words, you may have to name it in order for people to recognize that it is different from the way they are already doing their work. Start small. It is smart to start small, engaging the passion of those who believe in this work and using that passion as energy to build momentum. Creating a culture of interprofessional collaboration requires multiple reinforcing practices. Mutually reinforcing practices eventually become, this is just how we do things around here, a definition of culture. Let's check out some exemplars, the first three of which are IPEC Commission Officers Foundation Excellence and IPE Collaboration Award winners. East Tennessee State University is responding to the opioid epidemic through IPE education, community engagement, research, and clinical care. And it's won not just the IPEC Award, but the Lawrence C. Weaver Transformative Community Service Award that is put out by the American Association of Colleges of Pharmacy. Let's check out a video of how they're doing it.
Liz, there is no sound.
Oh, forgive me. I should have tested that with all of you. I could send you the links later. That means you won't hear the other one either. But I'll move on. Well, I'll just mention, I'll back up. The ETSU one has put naloxone in all their AED containers around campus. And when anyone opens that, there's an immediate call for help in the response to give assistance to the naloxone providers. And it has just been so successful in helping to save lives. And the next one that I want to call out is the Lighthouse Free Medical Clinic at the University at Buffalo. It's a drop-in clinic run by the University of Buffalo Jacob School of Medicine. It provides free routine healthcare and preventive services to uninsured patients in Buffalo. And it's staffed by an interdisciplinary team of med students working with the local health department and UB students preparing to become dietitians, social workers, dentists, lawyers, and public health workers. And it's overseen by medical faculty. And the clinic is one of the first in the country to build a medical legal partnership managed entirely by UB medical students and student attorneys. Pretty impressive. And then this is another video, but you probably can't hear it, so I won't try to play it. It's the University of Central Florida with the Farm Workers Association coordinates teams of students and faculty who provide free clinics for uninsured farm worker families. So all these videos are on the IPEC website, or I could just give you the links later. They're just really moving. And next is a humble example, not as much of an exemplar, but an example. Here are my parents' 4 artificial knees, and the first 3 went without a hitch, but the 4th one, my dad's left knee, he complained of some oozing in the wound, and we had 3 people coming to the house in various shifts, the nurse, the OT, and the PT. And the nurse discovered there was a staple left in the knee. And the communication among those 3 and with the doctor's office was absolutely beautiful. It was like a symphony. We just were so impressed. They were all a part of Team Dad, all supporting him to get to healing. And he recovered wonderfully and is still bopping around at 84 years of age. So these examples I've shared show that patients and populations, they're not exogenous, but integral to both our health system and our educational system. And their needs need to translate into demand for services. Next, are you ready for changing education for collaborative practice? We saw what FDU could do just a few weeks ago when you whooped Purdue. That was incredible. I think you're ready to take it up a notch in IPCP. Now I've got just a few questions for you to stimulate any time that we have remaining. Faculty, what do you envision for IPCP at FDU? Students, what do you need for success in your IPCP journey? Staff, what do you dream about to support IPCP? Partners, what kinds of IPCP collaborations enhance your community health and wellness? Leaders, how are you planning for IPCP that changes the health ecosystem? I'm looking forward to your thoughts, your questions, your ideas, and I leave you with an inspiring quote. The future doesn't happen, it is built. So let's build it together.
Thank you, Liz, very much. This was really, really inspiring, informative in the first place, and I think we all enjoyed your presentation. So, are you open? I heard you suggested questions now. Right?
Sure. If there's time, I'd love to hear any thoughts, ideas, questions. I'm here to learn from you as much as you from me.
Yes, I would like to encourage everyone to ask questions.
Elizabeth, my name is Ken Sternfeld, and my question to you is, first of all, thank you so much for sharing this evening. It was I think if anyone in our profession or any profession would see this early on in their professional journey, it would open up their mind and their thought to what can be done. I'm looking from a pharmacist perspective because I am a pharmacist. Were a student of pharmacy to see this, just this presentation, when they got their white coat early on in their curriculum, it would inspire them to do more. We must do more. My question to you is, to join ASPPH, are there any specific guidelines that would be required to become part of this amazing collaborative interprofessional relationships?
You are kind, and thank you. Yes, ASPPH has only one requirement, and that is to be accredited by CEPH, the accrediting body, or is on the path to accreditation, has been accepted to accreditation, and there is a cost that is associated.
As a follow-up to that, because what we do would not put us on that path. However, I'm committed to the vision and the mission that you have. Would we, as a experiential educator for Fairleigh Dickinson University, which I'm so proud to be able to collaborate with them under their umbrella if they are associated with the ASPPH, which I'm assuming they are?
Most definitely. We're open to all sorts of engagement. The field needs it. You know, we can't say no. It's just imperative. So look forward to any ideation you may have and assisting and connecting you with others who may be more appropriate if you have a particular niche thing that, you know, might not be met by something with us.
We do have that niche, and Dr. Bajani and Michelle will be speaking shortly about how we can do more for Fairleigh Dickinson University students in all of their colleges to really set a standard of care that I think we'll all be proud of. Thank you so much for this presentation.
Oh, thank you.
Thank you, Ken. Are there any other questions, comments? You can simply unmute yourself, or you can type the question in the chat if you would like.
Hi, this is Laura. I'd like to comment. First of all, thank you for an amazing presentation. And doesn't she have the most amazing speaking voice? It was really engaging. You know, I wrote down a couple of the things that you said, and you had said collaboration a lot, team-based, breaking down silos, and relationships matter. And you demonstrated how everybody is coming together to have interdisciplinary relationships, and the new way of education will be, is, and should be to educate new people coming into the health sciences fields and public health to learn how to collaborate. So it's more of a comment, but thank you very much for your very robust and informative presentation. It was really insightful.
Oh, thank you. It was fun to set up for. And you know, it's funny when you're asked to do something like this, everything you see relates. Everything. I read the paper, I want to put that in, I want to put this in. So it's just, you know, it's the time is now. There's so much going on in health improvement and healthcare and education. These are just really exciting times to be working in this field. The opportunities are just astounding to try to overcome together these challenges.
Mm-hmm. Thank you. There is a question. Is the April 25th town hall meeting virtual or in person?
Virtual, I should have said that. Yes. Yes, so try to come. I think we have max of 1,000. We're expecting a lot of people.
Mm-hmm.
So register quick if it's something you want to do.
Yes. I hear some students are already registered.
Oh, excellent. Wow, I love it.
Yeah. All right.
Hey, Liz.
Go
Sorry,
ahead.
one more. Liz, Michael. Hi, Liz. Great presentation. Have you worked with any governmental agencies? I see a lot of interprofessional collaborations during disaster management. I think this must be a great presentation for them.
Yes, yes. I'll just bring one to the fore here. SAMHSA, Substance Abuse and Mental Health Services Administration. They did fund IPEC. It's been a few years to have some regional meetings around substance abuse prevention. That was really exciting. It was small. It was one-off. They might have had some leftover funds at the end of the year. That award that I mentioned and the 3 exemplars all won the award is supported by the Commissioned Officers Foundation, a governmental entity of the Public Health Commissioned Officers. And there are many others. With ASPPH, funding has gone down in recent years. We used to get more from the government, CDC and others, but we still retain a little bit of funding to do work. And we have funded recently through CDC some interprofessional studies. Is that what you wanted to hear, or you're looking for something else, Michael?
No, that's what I
Okay.
wanted to hear. And
Yeah,
I'm also part of the Commission Officer Association.
Are you? Oh, wow.
Yes.
So, well, thank you for helping with that award. You know, it'd be good to get more. It's spread the word. We don't have a ton of applicants for the award. So, you know, those who put in have a pretty good chance.
Okay, sure.
All right. Thank you very much. Again, thank you, Liz, for wonderful presentation and overview. And thank you for leading us into our panel discussion with your presentation. Michelle, I'm giving you a podium.
Great, thank you, and good evening, everyone. I'm glad everyone here could make it. We have a nice crowd. Liz, I'm just going to echo everyone else in saying that was a great presentation. As most of you here probably know, it's National Public Health Week, so I think that is a wonderful presentation to really tie everything together. And then I know we have some public health representatives also on our panel, and then you know, pretty much there's so much interprofessional collaboration with public health and everyone else on this panel too. Everyone does great work. So I'm really excited that everyone could be here tonight. I'm going to just give a brief, name, credentialing overview of the panelists that we have. And then when they speak to answer their questions, they're going to give a little deeper dive into the work they do, because we want it to be fresh in your mind as they go to answer the questions about their interprofessional collaboration. So that being said, we have first up Laura O'Reilly, RN MSM, and she's representing our MPH program tonight.
Hey there.
And next we have Kelly Martins, LSW MSW, who is representing our social work program tonight.
Hi, everyone.
And then we have Caitlin Sanford, who many of you may know, OTD OTR, and she is representing our occupational therapy program.
Hi, everyone.
And next up, we have Ken Sternfeld, who a lot of you are also probably familiar with, PharmD, representing our PharmD program.
Good evening. Must say, the letters after my name are not accurate. I am a registered pharmacist, proud to be a registered pharmacist. I am not a PharmD. I don't want to misrepresent myself. However, I am a practicing pharmacist, and I love the fact that the letters after my name let me do that.
Thank you. That happens to me myself a lot. I get called Dr. Beauvais and I smile for a second and I'm like, I wish that was accurate, but it's not. So thank you very much.
Go with Doc, as long as that's good enough.
And then last but not least, we have Michael Serrano, MSPAC, representing the PA program.
Good morning. I'm calling from Taipei today, actually.
That is awesome. We're very glad you could make it and we appreciate that you're here. And then that being said, I'm going to dive right into our panel question. A lot of them kind of skim over the IPEC core competencies that our keynote speaker Liz was discussing. So I think it'll be a really great tie-in to her presentation. And then also, Liz, if at any point you want to chime in on any of the questions, that is great too. So I'm going to get right into it. And question number 1 for our panelists are, tell us about a time when you felt it was necessary to reach out to other healthcare professionals to achieve desired outcomes.
Will you be calling us, Michelle, or is it
Any
late?
of you can jump in first that volunteered for the question.
I volunteered for this question, and then I
Okay.
had seen the slide that Liz put up with the 4 knee replacements. For me, the time to get into this opportunity of interprofessional relationship came when my father-in-law was stricken with an adverse drug reaction that caused his existing knee replacements to get worse. And he got an infection, and he had to go back again to have both knees replaced. And when he did it the first time, he was very vigilant, and he was very, committed to it. And he ended up playing tennis and golf, and it was a wonderful transformational part of his life in his 80s. But when it had to be done again through no fault of his own, through a medication misadventure, it allowed me the opportunity to put family first and to say, how can we help my father-in-law deal with the fact that from head to toe, mentally, physically, emotionally, everything had been put in his lap that he couldn't deal with. So I reached out, and I reached out for the kind of care and the kind of support, and speaking to physical therapists, occupational therapists, anyone who would want to help my father-in-law get back through it. Sadly, his spirit and his fact that the adverse drug reaction gave him a feeling that he didn't want to be a guinea pig, and just have not people give him doses and medication that they didn't know was well suited for him. We lost him sooner than we probably should have. But it put me on a pathway for this interprofessional collaboration. And I was in 2014-15 when Medicare was coming out with chronic care management. We've talked about chronic care for years, and we do a horrible job in managing patients who have chronic illnesses. So I looked at chronic care as an opportunity for a pharmacist, even though CMS did not write us in. We are not considered providers, a whole other topic. And I really reached out to everyone, physicians, physical therapists, occupational therapists, nutritionists, people who are in social work, or people could help patient who needed care. And it became part of my culture. It became part of what I needed to do for a family member who I loved, who I lost too soon. So when Liz said something, the time is now, the takeaway for me tonight is really the time is now for us all to do what we need to do. And we need to do it today. We need to look back to Asheville, North Carolina, when everyone collaborated in that small city to create a pharmacist-driven care plan, where the pharmacist was the hub, who would basically coordinate with other care providers. They were coordinating the care interprofessionally. And we can do the Asheville project again, from Asheville to Zanesville to Main Street USA, because remote care and telehealth has changed the world of care. And we must do it. People are dying. More people will sadly lose their life because they are afraid to go for the care they need. And they have diabetes, hypertension, obesity, COPD. We must be proactive. We must go there. Everyone is a public health advocate. Everyone. A pandemic, everyone's a public health advocate. Doesn't matter what the letters after your name are. So that's what it started. It started with family. And it's allowed me to treat my patients now like they're my family, and to educate, empower, inspire, and then hire next generation. We call them remote care providers. And our School of Remote Patient Care educates not just pharmacy students and not just public health, MPH, but anyone who wants to care for a patient. Because I looked at our associations, and all of those 22 associations are wonderful for what they do. But there isn't one association in our profession, pharmacy, or I dare I say what on that slide, that has the word provider in it. We'd have to provide care, compassion, and empathy at a time in our lives when we are still in a pandemic era. So for me, it's personal. For me, it's about treating your patients like your family and hopefully inspiring others to follow their pathway. So that's what it meant to me, and that's what it was always mean to me, and why interprofessional collaboration is the key to outcomes. It's the needed ingredient that we must do.
Definitely. Thank you very much for sharing. And just for terms of smoothness, I think I am going to call on the panelists. That way, everything just runs a little smoother. So next for this question, going to dive a little deeper, we have Caitlin.
Sorry, Michelle, can you repeat it for me?
Of course, I know it was a while since I said it, so no worries. So for our first question, tell us about the time when you felt it was necessary to reach out to other healthcare professionals to achieve desired outcomes.
So I'm in a little bit of a unique position. So I represent the Fairleigh Dickinson Occupational Therapy Department as their clinical director. But prior to coming on board to FDU, I was a public school-based occupational therapist for 14 years. So my realm is a little bit different in that my clinical background is not so much clinical, but I practice as a clinician within an education system. So when you say, when did I feel like I needed to reach out? In my educational background as an occupational therapist, we focused a lot on our interprofessional collaboration with other rehab professionals. And it was very heavy in OT, PT, and speech, right? We kind of are like the three that go together, right? And then when I chose to pursue pediatrics, particularly school-based, it was a very different realm because I am at the heart a rehab profession, practicing more of a medical model now in an education system, particularly a public school. And I specialize in elementary school, pre-K and elementary school. And so that really threw me into an interprofessional collaborative role with different people that I hadn't necessarily interacted with in my education coming out. And so it became very quickly obvious to me as a new practitioner that I was a little bit out of my element as far as, I come from a medical model. I come from a very health-driven background, but now I'm collaborating with teachers. I'm collaborating with social workers, psychologists, school nurses, art teachers, music teachers, and principals who don't necessarily understand what I do as a professional. And so it really gave me that opportunity to kind of think, okay, how do I now shift gears? How do I take this, rehab background? How do I take my occupational therapy knowledge and translate it to people who don't work in the healthcare field? Additionally, an educational system is not driven by a payment system. There's no billing, there's no insurance involved. So when you are acting in a hospital or a medical or a clinical setting where billing is involved, it delineates your role a little bit stronger. It kind of says, well, this particular service is billed for this particular provider. This particular service falls under this particular scope of practice. And in the public school system, because there's no billing system, it's just sort of like, well, it's all hands on deck and everybody collaborates together. And the role definition isn't as clear, which I know we speak on this a little bit later in the panel, but that's one of the biggest challenges. And so that really is what forced me to say, okay, I'm a little out of my element as a new practitioner, and I'm not necessarily collaborating the way that I was taught or the way that it was facilitated in my education. And now I need to really do a deep dive. And after spending several years as a therapist, probably around year 5, it just started to become natural that I wasn't using the medical terminology. I was collaborating with the teachers on their level, and how they understood it. And I was collaborating with psychologists and social workers. And we were, OT has its roots in mental health. And it's an area that we are really strongly pulling back into. We are integrating more into that community and mental health. But when I graduated as an OT, it was still very much a medical model. And that has very much shifted. And so it just became very natural after a few years of practice. And then after 14 years, it became supernatural that the people that I associate with are more of the education model, not so much the health model. And so that's what really drove me to Interprofessional, feeling very much out of my element as a new graduate as a medical profession that wasn't working among your traditional medical professionals.
Great, thank you. And that gave us some background insight as well. So I do appreciate that. And then I believe, Michael, you have a little bit to add to that about when you felt it was necessary to reach out to other healthcare professionals to achieve your desired outcome in your profession.
Desired income is good too.
Right.
So for me, other than being an investigator with the FDA, I'm actually an active duty officer with the U.S. Public Health Service. So there's a lot of interprofessional collaborations during our deployments. And the one recent one that I was at, that I participated in, was in the unaccompanied minors. So it was a lot of minors coming through the border from Mexico to the US, and they called in officers to help out with managing that. And when we were sent out, we were a bunch of clinicians, pharmacists, social workers. And the first day was accountability. We have 2 docs, 1 PAs, 10 nurses, a couple IT guys. And so what are we gonna do? So the need is to have 2 clinicians take care of the kids for COVID vaccination and managing their care. Since we had 2 docs already, I was the only PA there, that they didn't need an additional clinician. So what they really needed was for a situational awareness officer, which is pretty much doing the census. And since they know that I was pretty good with Excel, they put me into responsible for conducting census for the entire mission. So my responsibility was to get the numbers. How many kids were coming in? How many volunteers do we have? How many clinicians are available, or nurses and ITs? And I would work with all the different professionals that were available in that mission. And other than doing my work as a IT and situational awareness officers, they know that I work with immigration, and I conducted a lot of nail avulsion for ingrown nail. So this is a common problem with immigrants coming through, or immigrants coming through the border, because they walk a lot and they don't have the good proper shoes. So there's a lot of ingrown nail problem. So once they see patients that would, the kids would come in that has that problem, they know that since I'm a clinician also, they would call me to do those work as well. But for this mission, we wore different hats for a lot of deployment or disaster management. We wear different hats. It could be a clinical hat, could be a non-clinical hat. But there's a lot of interprofessional collaborations during the disaster management. Thanks.
Thank you. And I think as we continue to go through our questions here, we'll see that all of the professionals on our panel wear many hats, just depending on the day. So I think that's really great. And then that being said, we'll move on to number 2 for Laura. What are the benefits and challenges for establishing interdisciplinary collaboration?
I am so sorry. I thought I was unmuted. Sorry for that little pause there. So I too wear many hats. So I'm going to just put this through a couple of different lenses for the nursing students, and Michael, who's a PA, gets the whole clinical thing. And then I'm going to contrast that with public health, because within the clinical setting, the benefits are you're all in the same system. You're using the same EMR, electronic medical record system, and you have access to different records and charts. And you could communicate with dietetics, with pharmacy, with OT, PT, and the various specialists to collaborate on care through a system. So a challenge in the clinical setting would be if one of the providers or one of the practitioners of a patient per se is outside of the system, then you're dealing with HIPAA, right, and protected health information. So there are steps that have to be taken to be able to collaborate with providers outside your immediate network. But so we see what the benefits are when you're in, intranet and intra-system, and going outside that system, you have to just overcome some obstacles. Within the public health system, the benefits of collaboration are tremendous. And this is the value that I'm bringing to our public students. I was recently a contracted executive director for the North Jersey Health Collaborative, and I was responsible for doing the community health needs assessment and the community health improvement plan for Morris, Sussex, Warren, Union, and Passaic counties. So my first day on the job, and I had been a member in Morris County representing boards of health. My first day on the job as executive director, I went to my first week, I went to the various counties, I met with the committees, and I would say, okay, so this group here, you're working on chronic disease and cancer. What are your goals? Where are you since the last quarter? And there had been no leadership in my organization. There was a little bit of a lag until they hired me. And I got a lot of blank stares and people saying the following. Well, the person who was leading our committee is no longer there. So we don't even know what we're doing. Or, I really enjoy coming to these collaborative meetings, but I have to go back to my full-time job as a public health nurse, and I can't take homework with me. I want to collaborate. I want to be part of this community initiative, but I really don't have the time. So I met with my various county committee leaders and public health leaders, and we came up with a new strategy. And we said, how do we really maximize the time of everybody who's at these meetings? So we all know that when we are at meetings, we want to walk away with some action items, and we want to make sure that the action items are achievable. So what we did was realize that we had to get leadership bought into the process, rather than have one individual employee of a public health department or of a human services organization accountable for the work. We went to the leadership and asked them to look at what their goals are for their organization and see where you fit into our community health improvement plan. And the unique thing about what's going on in community health improvement planning, as we all know now, is we are addressing social determinants of health, right? Our keynotes spoke about, taking an upstream approach to root causes in people's social situations. The only way we can address that is if human services is at the table, social services is at the table, healthcare, public health educators, health officers, public health nurses, and various other disciplines, law enforcement. The list goes on and on and on. And the benefits of this is that within these counties, right, we've got 21 counties in New Jersey, and if each county is coming together and they've got leadership in all of these sectors sitting at the table, all looking at the same goals and all examining how their mission of their organization and their department aligns with what these larger county goals are, we can solve some problems. And it's about relationships, right? So just to put it in a nutshell, some of the barriers are accountability of people who are coming to the table and trying to be in these cross-collaborative initiatives, but the benefits far outweigh any obstacles that we come up with. So again, the best approach is to really convene people in multiple sectors and make sure that the goals are clear, smart goals, right? That they're achievable and that they're measurable, and and that is one of the greatest benefits of collaboration and getting work done, is just making sure that all sectors are represented and that the goals are clear and achievable. Thank you. I hope that explained a little bit about how these collaborations can really be effective.
Thank you, definitely. And the mention of SMART goals is always welcome. That's always a great touch. And then, Caitlin, did you have anything to add to that question? What are the benefits and challenges for establishing interdisciplinary collaboration?
Sure. I mean, again, speaking from, speaking from somebody who worked in like an education system, but I think it applies really in all places, but logistics is always like a biggest challenge, right? And it's kind of a basic one, but unfortunately, if you don't have administration or leadership that's willing to support the time for collaboration, then that can get very sticky and it can get very difficult. So just from a basic logistic standpoint, I think that's a big challenge as well, along what Laura had just touched on with accountability, right? Who's responsible for what? And then who's, especially in a collaborative team where you may have a clear leader, but you also may not have a clear leader. You may just have a very good collaborative team, who's taking on the role of then making sure that the accountability is there. And that's always challenging. I will say though, I think one of the biggest benefits to collaboration from, again, the clinical perspective that I have is if you can work effectively as a collaborative team, for us, of course, patient care, right, and client outcomes, but then also being able to empower your team members to take away something from that collaborative relationship. As one OT in a public elementary school with a caseload of 50 students, it can be very difficult for me to make sure that I'm collaborating with every teacher, with every set of parents, with every session after the speech therapist has seen the child, right? But if I can work collaboratively, particularly with the teachers, to empower them to feel confident in utilizing a strategy in a classroom with a student, then it takes some of the pressure off of that burnout and all of the work that I need to do. And the teachers then feel empowered to say, wow, you know what, we worked so collaboratively together that there's just such a seamless transition of knowledge, and I can take that knowledge and now go empower somebody else for it. And I think that that's a huge, benefit, particularly again, and this applies in all health settings, but our families are part of that collaborative team as well. And so from a pediatric standpoint, one of the biggest benefits is making sure that the families feel empowered by that collaborative relationship to take ownership of their piece in that team. And then for our pediatric clients, like the routine and the structure, if they see that every member of the team that's working with them is collaborating, then they get the structure and they get the routine and they get the carryover and the generalization that they need from a healthcare standpoint.
Great, thank you. And then Ken, did you also have anything to add to that question?
Yeah, the benefits are obvious when we look at, the overarching outcomes and the patient. For me, the benefits have always been patient acquisition. When you collaborate with others, you expand your opportunities because you may be in a silo that approaches a certain demographic. But if you're collaborating with others who expand it, I've looked at it always as an opportunity to say, what can we do for you to help you expand your opportunities? And then I kind of come along for the ride. The challenge is, as a pharmacist, we seem to not be at that peer-to-peer level sometimes. So for me, it's always about, I expect nothing and then I'm really never disappointed. So I know there are enough opportunities out there. The challenges are not everybody gets it. But that's also the opportunity to kind of hone your skills about how to keep approaching others. So for me, it's a numbers game. The more people you can collaborate with, the more opportunities you have for the patient outcome and also for your opportunities within your own business practice. As an example, we never really worked with nonprofits, but now we do. So in the state of New Jersey, the Diabetes Foundation, there are 4 million patients with diabetes who they interact with. So looking at what is missing, their gap, is the clinical aspect of what a pharmacist can bring to them. So by identifying a gap in their business, or their model, we're able to go to them and say, let's fill that gap. The gap in care is not just prescribing a statin. The gap in care is looking at what the other practitioner, the other healthcare professionals would benefit from collaborative interprofessional relationships. And to me, the opportunity is boundless, because the patient need is enormous. So the benefit is better patient outcome at a time in our life when we've been through 3 years of a pandemic where we need that. We need better patient outcomes. We need to lower the cost of healthcare, and Interprofessional does that. We need to give practitioners more time to work with that model that in that slide about a 27-hour day. We've all gone through what this pandemic has done to the health continuum, but we have to change. If we don't change, anyone who says, well, we'll do it because that's the way we used to do it, they've kind of been living under a rock the last 3 years. This is a great time for innovation. This is a wonderful opportunity for exactly what every slide I looked at today can bring to the betterment, a better world that we all hope and pray that we can be there. So the challenge is don't give up. Just keep doing it. If we focus on the patient, that's who we work for. Sadly, there are too many patients out there who need our care. So to me, the challenge is staying focused and staying on point, and just saying, no matter what the challenges are, we're going to get where we need to go.
Thank you very much. And then for our next question, question 3, Kelly is going to be answering this for us. Please identify 2 factors that foster effective IP interprofessional collaboration.
Awesome. Hello, everyone. My name is Kelly. My pronouns are she, her, and hers. I'm the Director of Member Services and a social worker at Edge, New Jersey, providing LGBT and HIV medical and social services. So I'm just really honored and grateful to be here. As my fellow colleagues have graciously shared before me, working together and respecting one's perspectives in healthcare can and will lead to improved patient outcomes. I think 2 factors that foster effective interpersonal collaboration for me are communication and increasing mutual respect and trust among those working together. So let's start with communication. That seems like a no-brainer in practice, but it can actually be really challenging considering all the different people in the room that make up that collaboration. A former mentor of mine once told me about the 3 A's in communicating and working with others. And I was giggling when I heard Ken and Laura use the word accountability, because these are accountability, attitude, and affirmation. Those are your 3 A's. Simply stated, when people are accountable for their work and actions, they will get more done. The reasons are many, but the facts are actually rather convincing. When you raise accountability, you raise productivity. In terms of attitude, we alone determine our own attitude, and we have the option every day to decide what attitude we will take in the work that we do. Have you ever heard someone say, that person makes me unhappy? The fact is that only you can make yourself unhappy. It's the same with attitude. We shape it ourselves. Our attitude reflects how we view others and how we view ourselves. Finally, let's finish off with affirmation. Affirmation is seeing things in a positive way before they occur, putting yourself in the best possible condition and position to accomplish an act or an attitude you're seeking at that time. In closing, communication is key for better collaboration and effective workplace communication. Most importantly, though, it's recognizing that communication varies for everyone. So it's really important for us to create not only a safe space, but a brave place for people to communicate their thoughts and ideas, which fosters successful outcomes. Secondly, let's focus a little bit on creating mutual respect and trust among those working together on this team and collaboration. If you make someone feel that you respect their opinion and that what they think matters, it gives them the courage to speak again. They become more confident in increasing themselves, expressing themselves. That is important to remember when working with different peoples from different backgrounds, educations, and simply put, their cultural backgrounds. This factor creates an environment where positions in education do not intimidate or silence the voices of those who also share equal wisdom and input. As a social worker, that's really important to me. The goal is to provide the best level of care for the patient and/or client. When we learn to work together, the focus remains always on the patient and client rather than just the diagnosis or treatment that brings them to you. You begin to understand the complexities and different variables and challenges a person brings. So communication and listening to everyone's perspective and input truly does set that foundation. Thank you.
Great. Thank you for that wonderful insight. We appreciate it. And our next question is for Laura. How would you measure the outcome of an effective IP collaboration? And what was the evidence behind that?
Well, thank you. So first of all, it depends on what we're measuring, right? So if we're in a clinical setting, and we're using, again, electronic health records and medical records, and we're evaluating a patient's health outcome, there are various ways we could do that. We could first, by assessing the patient, looking for, a decrease or elimination of any kind of health symptoms, looking at what's revealed in the laboratory reports to see if there were improvements, a reduction in certain medications. There are, real objective types of data that can be measured in the clinical setting. When we're in the population health sector, however, you really have to determine what you're going to be measuring specifically that's going to lead to an improved outcome. So if we're talking about social determinants of health, for example, and this could be done clinically as well, upon patient discharge or emergency room discharge through the social work team, or through human services agencies and social services agencies, and even public health nursing. When the nurses are out there and they're doing blood pressure screenings, for example, right? Or you people who may be getting your master's in public health and then going on to become CHES, certified health education specialist, you're out there, you're interacting with the community. It's your chance to actually educate the community. If you're taking a blood pressure and you notice an abnormal value, that's an opportunity for education. It's an opportunity to ask a person about their medications and their knowledge around their medications. It's an opportunity to tell them, the pharmacist is your friend. Talk to the pharmacist. Don't ever change your medication. Talk to your doctor. Talk to your pharmacist. Just pick up the phone where you get your prescriptions. It's an opportunity to educate, right? And it's an opportunity also to connect with services. So here's where we could close the loop. So a nurse, she'll give education. She'll talk about, how to titrate a medication, how to, when to take a medication. If they're referring to human services or social services because you discover that a person's not filling their prescriptions, that's why they've got chronic hypertension, because they can't afford their prescription. This is stuff you'll see in public health. It's an opportunity then to connect them with human services and social services, which goes back to what I was saying earlier about collaboration. When everybody's at the table, at least once a quarter, and then you're out there in the field, you say, okay, I know this person who works at the Morris County, I'll say Morris because, the university is in Morris County, the Morris County Division of Human Services. And I know that if I connect this person in the community with her, she will take her and help her get the services. So that's not being tracked in an electronic health record. And public health is basically reporting on numbers of individuals that were impacted, numbers of individuals that attended a screening, numbers of individuals that attended vaccination clinics. Although with vaccines and the COVID vaccines, obviously the people who are being vaccinated are being tracked, but it's not like your typical healthcare setting where there's going to be a continuous relationship with physician and patient. So you have to know what you're tracking. So when you're looking at social determinants of health, you want to make sure that there's a warm handoff or a closed loop referral. And how can that be done? Well, that could be done through organizational tracking. Let's say I got a grant. You'll enter the world of grants in public health. I got a grant, and my grant is to impact individuals in my community. And I want to demonstrate to the people who are funding me, whether it's the health department or a private funder or the federal government, how many people am I impacting? And how am I tracking that? So you can track it, within your own organizational tracking system, Excel spreadsheets, or on a community platform. There's one called NowPow, for example, which is a community information sharing platform, where if enough organizations are on there, they could actually make referrals among the network within this platform, and you can see when the loop is closed and the referral has been made. But you won't see any clinical information in there or any protected health information. And then when you link in clinical to community, you're going to understand that healthcare systems and practices are very protective of their data and their health information. So, frequently there will not be an overlap between the two. So clinical will, has those objective hard data to follow. And in the community, we're dealing not necessarily subjectively, but it's more of touch points. How many people have we touched? How many people have we reached? And how many people have we referred to community services? Thank you.
Thank you. And just in that response alone, it tied in many different professions and showed how that dynamic works. So we do have 2 more questions. And then if we do have time, I'm going to circle back and see if any of the panelists have anything to add to the previous questions. So next for Kelly, can you please give us an example of an ethical dilemma in your interprofessional collaborations?
Absolutely. So as a social worker, my professional framework circles around the NSAW, which for those of you who don't know, it stands for the National Association of Social Workers. And so the Code of Ethics sets our standards and guide to provide professional conduct. So an ethical dilemma that occurred to me while working collaboratively with medical providers was unrealistic and conflicting goals, right? And as a social worker, for me, it's really important to foster a strength-based perspective and meet a client or patient where they're at, which means identifying the here and the now and supporting the person to make healthier choices. As mentioned in today's presentation, when Liz was referring to the social determinants of health, I had a client who was engaging in substance use and was also not stably housed. The client was not consistent with taking his HIV medication, and the medical provider was nervous that the individual was going to develop a viral load. The provider provided some very great strategies and alternatives to get the client to come to our facility every day so that we can do some medication monitoring. Although that was creative and doable, the client lacked the desire to take the medication in the first place, go into an inpatient facility, because his main concern was that he was homeless and coping the best that he could. So I want to talk about the housing first model approach, which serves people experiencing homelessness and recognizing that a homeless person must be able to access a decent, safe place to live and does not limit the stay before stabilizing and improving health. So communicating that concept to the medical provider was extremely valuable. Ultimately, I did not disagree with their recommendation, but it was necessary to push back just a little bit, just to explain why the actions of this patient are tribulations of their environment. With time, we were able to support the client by providing housing, by providing them behavioral health counseling, and taking medication as prescribed to reduce not only their social determinants of health, but also ensure that they will be able to live a healthy and safe life. So that was really valuable for me. And so as my role, especially at Edge New Jersey, it's really facilitating those conversations between interdisciplinary teams, between the medical team, the behavioral health department, the case management team. Had this person not found our agency, I can only imagine how many folks like this person exist out there, right? And so I know Ken mentioned nonprofit organizations and the work in supporting nonprofit organizations, but places such as my organization really support folks in that nature. So I hope that answers an ethical dilemma that found a solution. Thank you.
It definitely does. Thank you very much. And then for our final question for Michael, we have, what type of feedback do you prefer to receive from other professionals on the IP team? So in your words, more or less, what is effective feedback?
Sure. Well, hopefully it'll be a candid feedback from everyone. But I'll combine this question with 4 as well, since it kind of is related. So for disaster management, well, one of the things we do after is called the hot wash. Hot wash is pretty much an after action review or improvement discussion with the team. And several team members will come into the meeting, and we talked about, what happened, what happened, what needs improvement, what was the successes, what was the failure, but no critiques in any of those. And then we try to find what data that we need to collect, verifiable data from the mission, like from what Peter Drucker, management consultant, he said, what gets measured gets managed, right? So from these discussions is, what Laura said, there's several types of data that we'll need to collect, but we don't know yet until we find after this discussions. So after this discussion, we'll look into more what we need to collect from the mission, and then from that we can learn from the mission and without any blame. And then from there we can teach the team to teach itself very much. But for the feedback, hot wash is probably one of the ways that we can get opinions from all the team members, the feedback from team members.
Great, thank you. That was a wonderful response to the last question. I do appreciate everyone on the panel for their time, for their expertise, and even just how you were all able to roll off of one another and speak to the other one's profession and how you've collaborated with them. I think that really speaks to how imperative it is to collaborate interprofessionally and really establish that effective communication line. So I do appreciate that. And then now I'm going to turn it over back to Dr. Berek Stojcik, who is going to take us into our next session, perhaps.
Thank you, Michelle, and thank you everyone so much. It's such an enlightening event tonight, talking about your personal experiences, professional experiences, talking about established knowledge, publications, research, and that supports interprofessional education and collaboration. I think it's such a really great learning experience for me. So I would like to ask that we engage in discussion with presenters and also with, to sort of to reflect on everything that we heard and saw today. So my question, we prepared some of the, guiding questions, but I would like to hear if there are more questions in the audience. One guiding thought we had, what stood out to you as a student, as a faculty, as a practitioner, what it is that you will take as a really something very important in terms of interprofessional education and collaboration? What stood out to you from all of these presentations and discussions? You can just simply unmute yourself and just let me know. I can highlight who is.
What stood out to me was looking at, of course, the leadership at FDU and faculty and leadership from Liz, and also looking at students of pharmacy who I personally have had the pleasure of mentoring as a preceptor for FDU. It's the something old, something new process. We're really creating a marriage we're kind of renewing our vows to the pharmacy profession, at least for me, but to our healthcare profession. And it's a time to do it and to have the next generation of public health advocates who I've had I'm not going to call off the names like the Academy Award, but they know who they are. They've made a major impact in my life, in my career, by having the mentor-mentee relationship. That is really, you talk about interprofessional relationships, the peer-to-peer and paying it forward. What I am taking away from today, which I knew also I had, was I have long-term relationships now with these individuals who they know that if they ever need anything to help them advance their career, it's my pleasure to do that. And we need to pay it forward. We need to do mentoring. We need to educate, empower, and inspire the next generations to do more than flip burgers at CVS. And I'll just leave it at that.
Flip burgers, let's see. I would
Thank
like to
you,
add
Jen.
something, if I may, Bayana.
Yes, of course.
Liz said something that really resonated with me, and it's so critical because I mean, I say it ad nauseum, a whole person approach. That is the foundation of the nursing process, right? The nursing assessment is we do a psychosocial assessment. We do intake and output, and we look at the whole person, not just what's happening at the point of a symptom or the chief complaint, but everything else that's going on. So if there's anything that the students can take away from what I say, it's please remember that, we have to look at all of the circumstances that shape a person's life. And there is, one of you just put in the chat that this presentation of this department has given you hope for the future of healthcare. And I have to agree. Everybody's all hands on deck trying to address all causes and make every citizen and every person, in our county, our state, and in our country have the opportunity to have good health and good health care.
Mm-hmm. Thank you, Laura. Someone just placed, and I think everybody saw that this presentation gave me hope on the future of healthcare. And this is the future of healthcare, interprofessional collaboration, and in the interest of individual patients, but also populations and healthcare itself, healthcare professionals. Everyone is changing. So, it's true. Our generation and even younger generations, I think Caitlin mentioned that we were all trained in silos and we were prepared to work our job well. And it was a good training. But we are living in a different world and demand is different. So we do need to reach out and collaborate, communicate, and work with other professionals with the patient in the center, with the patient being a focus of not our professions, but the patients, or clients, or community, popular public, is the center of our interest. And I see another comment here: presentations tonight definitely act as testament on the importance of collaboration between all healthcare fields. And students are adding their agreements to each other with this statement.
If I could just chime in, from a
Sure.
student perspective, I want all the students on this call to consider the reason why you are pursuing the career that you are, right? Whether it was a personal circumstance, whether it was a drive to make a difference, that is what I call passion. For the educators on the call, I want you to also consider what drove you to do the work that you do. And for most cases, it's also passion to make a difference. And so the takeaway that I hope that you, in addition to the awesome presentation, is that there is also passion in building collaborations with community, because we can't do this work alone. We can't work in a silo. I think the pandemic showed us what happens when we as humans don't have human interaction. And so if we continue to spark passion moving forward, and sometimes passion is coupled with anger and frustration, which also leads to successful outcomes when you use that towards your passion to change. And so I just want to thank everyone for an opportunity to be here today. Laura, it's awesome to see you. Laura and I have worked in the past together.
Yes.
So another thing,
Thank
do
you.
not burn your bridges, because likelihood in this community partnership is that you will meet again.
As we always do. I would like to thank everybody for the opportunity for having me here today. And this is a shout out to Kelly and all the social workers. I say this in my work and as a family advocate for anyone who's in the hospital. Social workers are the fiber of the thread of society, whether it's in the community, in a healthcare setting, in a social setting. Your social worker can really tie all those pieces together and lead you to all of your resources. So utilize them in your current and future work. Really tap into the knowledge of social workers.
Thank you. Laura, I usually say that for public health workers. That
Same.
we
Yes.
do connect. Yes.
Yes,
But I
same.
But you know, when you think about all of the professions, we all are supporting each other. We are working together, and I think this is the beauty. One final question I have for primarily faculty and students. What would be valuable addition to your courses from everything that you heard tonight? What would you add as a faculty? And I'm pretty sure that some of us faculty are thinking about some, and we have some ideas, but also students. I would like to hear what students think would help in getting closer to this new model of trans or interprofessional preparation. And I would really like to hear both faculty and students. Thank you, Andrea. Health communication is a valuable class. That could be the place where we can work on interprofessional education very well. And Ken, yes, I agree that we all are students of transformational professional change. Think about any other course, not just IPE course. Oh, I'm sorry, Nicole. I'm sorry, I didn't see you. It's such a, there are so many people on my screen. I'm sorry.
That's okay, Boyana. Sorry. Yeah, so I think for me as a junior faculty at FDU, one of the things that I think would help me conceptualize and facilitate IPE is more opportunities to really collaborate with other faculty, just to even get to know more about the work that they are doing and the things that they are what their curricula looks like, because as a clinician, I've always believed in this parallel process. So the things that are happening among staff and the opportunities for collaboration among staff, those things kind of naturally, organically happen for the clients that we're serving. And so I think, as I think about some of the conversations that I've had interprofessionally, having those conversations with faculty and really getting to know everybody in the School of Pharmacy and Health Sciences, I think will naturally help create some of those smaller pockets that I think Liz was talking about as part of her keynote, that, we can really capitalize on when it comes to really developing a good IPE curricula across our programs.
Thank you. Yes. I agree very much. Right. Scholarship of teaching and learning communities might help. That's true.
Jana, I have one
Yes.
comment that always bothers me about student debt in all professions. Would it be possible if the focus of this this transformation could go along with financial considerations for those individuals who step up? Because at the end of the day, financial student debt is a chronic disease. So if we're looking to deal with chronic disease, but are not addressing the burden we put on our next generation professionals, I think we're missing, that's a gap in care for the care providers who would embrace this initiative, in my opinion. And we should look to create a, interprofessional student debt program, putting them in the community like teachers do, working for the common goal of public health overall, if they can embrace this initiative. Just a thought. I don't have any student debt, but when we talk to our students, they're burdened with it, and they'll take jobs that maybe they don't want because they need to retire their debt. Just another thought about what we all can do to help the next generation of providers.
Thank you, Ken. That's a valid point, and that's actually, now if I can share a little bit, one of my students in previous university did her capstone project on developing a team of professionals to work with students, college students, and address the financial issues, exactly what you were talking about. So I think this is something that's needed, and it could be done very well in collaboration outside of School of Pharmacy and Health Sciences, in collaboration with School of Business or with School of, other programs that we have on campus and on other campuses. So I think this is a current issue, and it's a health issue also. I agree with you.
We do have a farm debt relief program that we initiated at our School of Remote Patient Care, and we have affiliate partners who believe that they can assist us. So again, there is monies available by doing good. And we're not talking about grants or things like that. I don't, that's a whole different world. But if you have affiliate products and services, which these next generation providers are recommending to enhance patient care, those manufacturers are benefiting by the expertise, the recommendation of healthcare professionals. And there are affiliate opportunities where they will reward you. I take all of that revenue and put it into a fund and reward the individuals who go into the community, who embrace what we are talking about as remote care providers. I'd be happy to share that with the members of FDU or anybody. We need to do something about financial debt of these students coming into our market in all healthcare entities.
Thank you. Thank you, Ken. So action items, can we identify for all of us something that we will be doing, each one of us, what it is that we will do next thing in terms of interprofessional education, interprofessional collaboration, communicating and collaborating with other faculty. We have several projects. We have a research project that we are working on between two interdisciplinary and so on. So being involved and just really learning, as Nicole said, learning about other professions and other curricula in our school would be such a great opportunity for action. And our IPE committee council actually has that opportunity to take some of the activities and actions on and to take us to the next level. We have a great support from the school, from the university, and so on. So I think this is something that is. Any other thoughts? Any specific comments?
Boyana, can I jump in for a second?
Sure.
Is that okay? You talk about action items. So wearing the hat of the clinical director for the occupational therapy program, one thing that we as a team have been very conscious of is really trying to partner with so I was a fieldwork educator in my prior role. So I stood on the other side of the fence, and now looking at it from the perspective of I'm the one that's setting up our affiliations for our students to go to. One thing we're really trying to be conscious of is looking at some of these new niche areas, or maybe not new or niche areas, but non-traditional areas where OT practices, to really expose our students. Because, for us, and we can always brainstorm, but I know that I found from taking my students that I learn from them as well. And I think I can speak for everybody when we say we learn from our students in the classroom as well. So making sure that our students have exposure to areas where they're going to see interprofessional collaboration in new and innovative ideas, so that they can bring that back to us and say, here's what I've learned, and here's what I want to take forth in my practice. And so that's, I think, one of my action items to walk away from immediately is, okay, well, where can we partner that OT fits in, but maybe OT is not the primary, practitioner? How can we show that, we can be a part of that intercollaboration team? And so that's something I think is really exciting and a really good action step for us to do.
I had a question
Thank
before
you.
the symposium, and I hit the wrong button to respond, and I got to Caitlin, who I had never met. And she said something like, I don't think you're the person, I'm the person you want. You need to talk to Michelle. I said, okay. And she said who she was, she'd be a panelist. And she talked about occupational therapy. And I said to her, and I say it again, I said, this is an individual that I said, I'd love to talk to you right after the symposium about how we can bring, I work with occupational therapists and we educate them. And I said, I'd love to collaborate with you. So just with the simple misstep of hitting a reply button, it turned out to be an opportunity to get introduced to somebody. And she's launching her program, I guess, or has the program, and then as a nurse, what do we want to do it? So it's just a Nike moment. Let's just do it.
Look at that. That's perfect.
Let's just do it.
So thank you very much, everyone. I'd like to express gratitude to all our speakers for leading us through learning about the challenges and benefits, evidence and successes that IP interprofessional collaboration has on population health. Much appreciation to all participants who contributed to the discussion and learning. Again, thank you to Justin Sgombik again and his team for excellent support, and thank you to Dean Rifkin and IP Council for support, guidance, and encouragement of this symposium. So we would really like very much your feedback about the symposium, your experiences at the event, and Michelle is going to place in the chat if she already did. Survey, if you can take this survey and give us, it's just really a few moments. It's just a very, very brief feedback that we need to sort of work on improving or addressing some of the issues that you might identify. And so that would be all. I see, Michelle, you placed it there. So thank you very much all. And with this, I would like to close the symposium at the moment and wish everyone best. And thank you again. I'm going to stop recording.